Good morning, everyone. Today I am so lucky to be joined by Andrea Martin. Andrea is a nurse practitioner. She specializes in all things sexual health and in menopause. And she's just logged in. So we're going to be chatting about sexual health and menopausal health. And as always, we will save this so you can review it later. There we are. Good morning, Andrea.
Good morning.
How are you?
I'm so good. Thank you for having
Thank
me.
you for being here. The first question is so important, and it is Andrea Explains It All as your tag name an homage to the Nickelodeon masterpiece that was Clarissa Explains It All?
Obviously. I am a child of the 90s, so that was a very important show during my upbringing.
It was in mine as well, so I love it. I love it so much. And I love the education that you create, and I'm just so thankful that you're here. So can you start by telling people about your clinical practice, what it is you treat, and your passion areas?
Sure. I'm kind of lucky. I get to really specialize in the things that I truly enjoy treating. So that can be anything from pelvic pain in general, pain with sex. It doesn't have to be just with sex. There's a lot of pelvic pain out there that I help treat, vaginal dryness, those muscles that are too tight, issues with skin like vestibulodynia, vulvodynia, um, help patients that are having trouble with libido, their sexual desire or orgasm. And then, of course, love taking care of patients that are perimenopausal, postmenopausal, all those types of things. So I love it all.
I love all of those things as well. And I love your approach to it. And you recently passed your NAMS exam, and that is no small feat. I understand how challenging that is. Can you explain what NAMS is and what people that have that certification specialize in?
Sure. So NAMS, they've been kind of semi-recently changed their name. It used to be the North American Menopause Society, and that's what we're all used to calling them. And I keep calling them NAMS, and I have to stop now. It's like the Menopause Society, more than just North America. Everyone is welcome in menopause. so, so yes, this exam, not a fun one, but it is done. But basically, yeah, you there's like a clinician's guide that can study, and there's all kinds of clinical referrals and this and that. But it's kind of I guess a general basic way to ensure that somebody who says that they're a specialist in menopause has like the basics of what it takes to care for a patient in menopause, which is, not just hormone therapy, but just general health when it comes to a postmenopausal patient, like what happens to your heart, your bones, things like that. So, yeah, so I took my test, and along with a lot of other people passed. This is one of I think, the largest cohorts of people that have ever passed, and then and taken the test in general. I mean, and I know the NAMS, or Menopause Society, conference that's coming up in September is actually sold out. That I think that might be a first time ever type of thing. So lots of interest in menopause.
There really is. And I've really seen the dialogue about hormone replacement therapy and overall management of hormones during the perimenopausal and postmenopausal state increase significantly because there's been some new evidence supporting more use of hormone therapy. What do you feel like is the biggest misconception around hormone replacement therapy?
The biggest misconception is that it's going to give you breast cancer. Usually, when I ask somebody, "What's your first thought?" You hear estrogen, this or that. It's like, well, I'm going to get breast cancer. Um, I even specifically remember when I was in nurse practitioner school, them I don't remember what else we were learning that day, but I feel like it was like a slide that was like, we used to do hormone therapy, but we don't do that anymore because it causes breast cancer. And it's funny at the time, of course, in my brain, I was like, oh, thank God, one less thing I have to study. There's so much else to study for. And then, little did I know at that time, no understanding of the consequences that had on women. And funny enough, now, I don't know, karma, it's one of the things that I have now studied the most. But there is so much misinformation, and a lot of that about, the breast cancer risk came from a study that results were released in July of 2002. It's called the Women's Health Initiative, or WHI, we usually call it. And they actually held a press conference at the Watergate Hotel. So this is like a big deal. Like, everybody throw away your hormones, you're going to get breast cancer. Matt Lauer was talking about it. Like, it was on all the big news media outlets. And rates of prescription of hormone therapy dropped by 70%. We've kind of come to find out now that there was a lot of issues with this, the way the data was interpreted and announced. Like, a lot of the main investigators in the WHI didn't even know that they were going to be announcing this. They hadn't even gotten to actually look at the data and analyze the data. They've since gone back and done, I want to say, like 4 post hoc analysis where they go back and reanalyze this data, and they're like, no, this does not cause breast cancer. In fact, estrogen alone, and this is another big meta-analysis that came out in 2024, so very recently, said estrogen by itself in women who specifically in these studies had a hysterectomy, it decreased their risk of breast cancer. So this kind of ongoing false idea has been a very difficult one to kill, but we're trying. We're getting there.
Slowly but surely. And I think the spread of information has increased even since then. So perhaps we can get somebody, not Matt Lauer, but somebody else to help us.
I know, he really loves women. He's so supportive of women. I love him as a spokesperson for women.
Yes, we'll get a woman.
I know.
How about estrogen and progesterone together as a team? Can you explain why often estrogen and progesterone really need to be prescribed together? And in some cases, in different applications, such as vaginal application, it's different. I think people get confused as to why they're getting a vaginal cream of estrogen, and then their oral or their patch might have different things in it.
Sure. It's super confusing. I know it's so much information, and then I can only imagine as a patient, you're just like, what? I'm doing what for what? So there's like vaginal or local hormone therapy, which is when you're applying, basically the options are estrogen or DHEA, which is kind of a precursor hormone that can branch off into estrogen or testosterone. But those are used specifically to treat just the vagina, the bladder, the vulva, urethra, all that stuff. It's not reaching the rest of your body in any significant level. Most women are going to need that at some point in their life, either postmenopausal, or we do it all the time. Patients sometimes need it that are on birth control, that are breastfeeding, things like that. So vaginal estrogen has a very specific role. Super, super safe. It's another kind of tricky area where all these general guidelines about estrogen get applied across the board, whereas vaginal estrogen is its own thing. It is ridiculously safe. I believe it's over the counter in Europe. And then there's systemic estrogen, so whole body estrogen, which that's going to help you more with things like hot flashes, night sweats, protecting your bones. Vaginal estrogen is not going to do any of that stuff. It is only working where you put it, but it's so great. It helps prevent UTIs. It's fantastic. But the thing is, most women, if you put them on systemic estrogen therapy, for whatever reason, I don't know why we're designed this way, it just tends to not quite reach the vaginal area. Those are like the last tissues that tend to get benefit. So a lot of times you have to use both. So I know sometimes there's fear, and I've heard this from insurance companies, pharmacists, things like that, like, well, you're on vaginal estrogen, we can't give you whole body estrogen too. That's too much, but that's not the case at all. We got to treat both. And then your question about progestins or progesterone. So I guess to kind of define things first, progestins are like synthetic progesterones, and progesterone is the like body identical, bioidentical. It's the chemical that your body makes itself. So there's some different roles for progesterone in our body. But if you are a postmenopausal woman and you're going to take whole body estrogen, not vaginal estrogen, but whole body estrogen, and you have a uterus, you have to take some kind of progestin or progesterone, because the one thing that estrogen does, well, we don't really want it to do, but it does anyways, it stimulates a little bit of the uterus, and it can stimulate the lining to grow. So if you are premenopausal, okay, whatever, you'll get a period once a month, it'll shed, we're fine. But postmenopausal, with time, we're talking like, years, it could start to kind of grow. And then the worry there is if you just left that forever, you could be at risk for uterine cancer. You add in a progesterone or progestin, it totally negates that risk. So that's why they kind of go in tandem. You have to have both if you have a uterus. But I will say, we also use progesterone for other things too. And you don't have to have a uterus to use it. So we use it like it can be really helpful for sleep. A lot of women in the menopause transition are having a horrible time sleeping. So it helps with insomnia. It can help with mood, anxiety. There's some data that shows that it might kind of work in conjunction with estradiol and helping with bone. But again, just to reiterate, if you are just taking vaginal hormones, vaginal estrogen, you don't have to take a progesterone with it. It's not going to stimulate the lining of the uterus.
Thank you so much for shining light on that. And additionally, when those are applied, especially the vaginal estrogen, it can help with lubrication and overall health of the tissue. I think one of our colleagues is quoted as saying vaginal estrogen creates beautiful, healthy tissue in the vagina.
Yeah.
That can be really helpful for urinary health. It can also be really helpful for sexual health. What do you think are some of the most common misconceptions that your patients have surrounding their sexual health as they go through that menopause process?
It's funny, a lot of times you kind of have to dig in. If you just kind of leave it at like any issues with sex or whatever, like, no, like, does it ever burn after you have sex? Well, yeah, sure. Do you ever have like bleeding? Well, yeah, a little bit here and there. And this is more than just like, you need to use lube. Like, lube is great. We love lube. It prevents friction. That's its main thing, to prevent friction in those micro tears. But if you've got like really thin, dry, delicate skin to begin with, I don't care how much lube you apply. There's only so much it can do. So, yeah, just kind of understanding that it's not just like, it's not just like, oh, that's how it is and now we deal with it. Yeah, sex kind of burns, it kind of hurts. What are you gonna do? I'm always like, it doesn't have to. They're like, oh yeah, I guess not. So there's definitely that aspect. I think a lot of women don't know also that, so that the technical term, for like vaginal dryness, it's genitourinary syndrome of menopause. It's a mouthful, but named that way because, again, it's more than vaginal dryness. Accepting phone calls. But anyway, the people don't necessarily understand that genitourinary syndrome of menopause gets worse over time. So what may be like a little kind of mild itch or a little soreness here and there when you're in your 50s, for someone who's untreated, by the time they hit their 70s or 75, I've got women coming into my office that can barely sit down because they're in so much pain because the tissue has just kind of transformed so much. So I think that's kind of a big misunderstanding. And again, and um, the fact that we are more susceptible to urinary tract infections as we get older, and using vaginal hormones can, it's, to me, it's like the most important thing you can do to prevent them.
That's so helpful to know. And hopefully that's going to drive more people starting to ask questions. I think that there's still a lot of providers that haven't heard or read the new data. And so they are giving pushback onto some of their patients who are requesting it. What advice do you have for patients who have heard about the new data and the new support, and they are ready to start that process and get some healthier tissue on board, and their provider is still in the previous frame of mind surrounding.
I know. It can be really tough, and I do not envy patients that are in this situation. Um, there's a couple of different ways to go around this. Um, at the end of the day, if you've got someone that is just absolutely like not going to work with you, not interested in the data, you know, my way or the highway, it's time to find somebody else. Like, there's only so much we can do to change people's minds. But I do think there are ways to kind of come at this in a way that is both, you come at it confident that this is something that is important to me and that I would like to address. And, if you're interested, I have these studies, I have these resources. If you're not familiar, I know we can't possibly know everything about everything if you want to read more. Um, but I get that there's different levels. Sometimes as a patient, I think, like, God, why should I have to be doing this work? Why, it's frustrating, but a lot of patients have to. I think it's also helpful, like I said, with a menopause society certification, at least there's some kind of like minimal amount of education there, like maybe starting with somebody who's certified. Or even with now, you've got so many people that are on, social media, things like that. You pretty much have a good idea of what they are comfortable with, what they believe in. So sometimes going that route, like, all right, I already know her stance on this. I know she's educated on this and that. Or even reaching out to see if they know somebody in your area can be helpful. But especially vaginal estrogen, it just should not be a fight. It just shouldn't, but I know it is.
So interesting, isn't it? And we get the same thing in pelvic health physical therapy about patients being told to have a glass of wine if they're experiencing pain with it. And we know that that's not the remedy.
No.
You said lubricant has its place, but certainly we want to be supporting the actual tissue itself. And you also love our dilators for that process and that training as well. Can you explain how you educate patients with the dilators who are experiencing discomfort with intercourse?
I do. I love dilators and I love the wands. I was showing somebody the dilators yesterday and dropped them all over the floor. So they're
Pretty rainbow of
I
tools.
know it was. I had a patient once. She had like her little boy in his stroller. Poor mom is trying to deal with her pelvic floor dysfunction, and he saw like all the colorful dilators lined up. Like, ooh, pretty toys. But yes, I love them so many times. So we've got kind of that irritated, dry skin, the thinning skin, and we can treat that with the vaginal tissue. But a lot of times, especially if this has gone on for a long time, after a while, the muscles kind of underlying underneath the tissue are kind of like, what the heck's going on up there? Like, I think we're in danger. Maybe we should all let's just clench, because I think that's a safe idea. If there's something bad happening, we will just clench. And then they just forget how to let go. So, and that can lead to pain over time. If you've got these muscles all the time that are just clenching and they're compressing blood vessels, you're not getting good blood flow, they're compressing the nerves, like it hurts. And I'll hear a lot of times like, it feels like, I try to do any type of penetration or whatever, it feels like I'm hitting a brick wall. So the dilators are a great way to just help, especially the muscles at the very opening. I call them the cock blockers because they're usually the ones that are like, they're the bouncers that are just like, nope, you shall not pass. So you bring the dilators in, and then it's just that gradual stretching of the muscle stretching. They're like, all right, I gotta get used to this. And eventually the muscles help, they kind of remember, like, all right, we don't need to do this all the time. Um, and then the wand is so great for reaching those deeper muscles in the back of the pelvis that could be tender. And it works with the ones at the opening too, of course. But I always like to explain it like you can get a sore muscle, a tight muscle anywhere. And I walk around sometimes. I always have pain up here. I've got the wand and I'm digging into my shoulder and I'm using the vibrating wand on that muscle. I'm like, it's the same thing. They're just kind of harder to reach. So I know a lot of times patients are like, I don't want to hurt myself. I don't want to break something. I don't. I'm like, it's no different. You got a muscle here, it's sore. You kind of work it out. Same thing. That's all.
That's exactly right. And one of the cues that we like to give if patients are worried about how much pressure is, we use the amount of pressure that we would use to check a tomato for ripeness. So if you're giving your tomato a little bit of squish to see if it's ripe, see if it's ready to use, it's the same principle with the wand or a dilator or a finger when we're working in a therapeutic way. Now, certainly pressure can be altered for pleasure, and that's up to the individual in charge of that body part. But at the end of the day, for therapeutic purposes, it's very safe. Just gentle sweeps.
Absolutely. I know. I never look at tomatoes the same way ever again.
Well, now on, I'm going to refer to the levator ani as cock blocking muscles.
They are. Especially that stupid transverse parity, I feel is always just like,
How shall not pass.
no. I'm like, okay, you need to slow your roll.
That's right. Oh my goodness. Well, is there anything else that you would like people to know as they think about this process and as we close?
I think I just want people to know, and they already know it, but they don't know they know it, that like you just got to trust yourself. If there's something going on in your body, your pelvis, your sex life, that menopause transition, you already know. Because I tell you half the times, I don't even have patients walk in the door, they already know what's wrong. If you just listen to them, they will tell you. And if you don't get the answer that you think is right or you think you deserve, or you get an answer that's kind of like you said, have a glass of wine, like, go take a bubble bath, this or that. Like, if it's not going to serve you, you deserve to go find somebody else that will help you. You shouldn't have to. I wish you could find the help immediately because that's what you deserve. But trust yourself. If there's something that could do better in your life and you want to improve it, go for it.
That is solid life advice.
Yes, I can't tell you how many times patients, because they've just been told over and over, because nobody knows what's wrong, that they just tell them it's anxiety, and they're like, well, I guess this is, and I'm like, feel this muscle here, like this is a physical thing. I should be able to press this muscle, and you shouldn't be jumping off the table. I was like, is that in your brain? I don't think so. This is real. And they're like, I said that at first, but then nobody. I'm like, no, you were right.
So
you were right.
you are not crazy. This is real.
No, the other people are crazy.
Yes. They need to pick up some literature.
Read a freaking book, people.
Well, Andrea, thank you so much for coming on today and sharing your expertise. And Andrea and I will be together in Chicago at the Menopause Society conference.
Yes, we will.
September, I don't even know, in September.
Yes, summer, mid-September.
Yes. And we look forward to seeing all the providers there. And we'll probably be doing some more fun videos like this as we go along. I think it'll be beneficial for everyone.
I think so too. And I think Clarissa Explains It All should have talked more about sex and menopause on her show, quite frankly.
She's our age. This is exactly what she should be doing.
Yes.
All other shows are getting a reboot. Clarissa Explains It All. You and I should be the writers on the show. She can wear the food. I mean,
Menopause edition. Here she comes.
That's exactly right. And she can tell us how to get through this new phase of life, just as she had to be a teenager. Thank you so much, Andrea. I appreciate your time and your expertise, and I look forward to seeing you very soon.
Thank you. Me too. Have a great rest of
You
your day.
too. Bye.
Bye.